vitamins, and as you know, we have quite a big part of them inside our body. So in the first, we will slightly and briefly introduce the topic vitamins, and then we will go through both groups of vitamins. That means the water-soluble vitamins and fat-soluble vitamins. And for each of them, we will slightly review its structure. Yes, of course, we do not expect you to be able to draw it, but we will review it. We will mention what's the active cofactor. Typically, they serve as the enzyme cofactors inside our body. Then we will mention when we can find them in the metabolism, so what's precisely their role. Then we will look at their source. And then we will, when it's important to mention some diseases, that means typically the deficiencies of vitamins. Per each vitamin, you have also the recommended daily intake. That means the amount of vitamin that you should consume or produce by our bacteria per day. So that's for you also to see, especially those that have too low or too high recommended daily intake. Of course, you do not have to memorize it precisely, whether it's 1.1 or 1.2 or 1.3. It doesn't matter, but approximately you should know the value. Yes, for example, that vitamin C is 60, 80 milligrams. And then, for example, vitamin B12 is, on the other hand, at very, very low doses, 2 to 3 micrograms. So this you should know at least the range. So if we start with the vitamins, according to structure, we cannot say almost anything, for they are quite heterogeneous group of organic compounds. And you can see some characteristics that we have fat-soluble vitamin and water-soluble vitamin. That's true. But for example, for water-soluble vitamin, the structure is really very heterogeneous, as you will see. Sometimes you have quite big compounds, sometimes you have only very small compounds. And what's the same for all of vitamins is that we cannot synthesize them, yes? Or what we can say, we can synthesize them only in some small quantities, and therefore we must obtain them in the diet. There are some exceptions. For example, some bacteria in our large intestine can produce some vitamins. For example, biotin is produced in our large intestine in quite high quantities, but not by our body, but by intestinal bacteria. And the story about vitamin D we will mention when we will come to it. So the first thing is heterogeneous group. We cannot synthesize them. We must have in the diet. Second important note is that vitamin for human cannot be vitamin for everything. That means that different species have different vitamins. Typical example is, for example, vitamin C. Vitamin C is typical vitamin, for example, for primates, for Guinea pig, but majority of animals can produce it. That means that vitamins are species selective. Third important note is that when we, for example, say vitamin E, that doesn't mean that you have only one compound. Typically, the vitamins occur in the form of multiple compounds that we call vitamers. So here we have example for vitamin A. We have it in form of retinol, retinal, or retinoic acid. As you see, alcohol, aldehyde, and carboxylic acid. And that you will see for many of them that the term vitamin means typically a group of compounds that have the same biological activity, and these forms can be interconverted inside our body. So we cannot produce them, but we can interconvert them. Two basic groups of vitamins according to their structure and their polarity. That's the water-soluble vitamin, where we can name two subgroups, B group vitamins and vitamin C. And then the fat-soluble vitamins, where you have those four routinely known compounds, vitamin A, vitamin E, vitamin D, and vitamin K. If we look at the basic characteristics of these groups, So we start with water-soluble vitamin. As we see in their name, they must have the hydrophilic structure. The structure can be highly different, but they share the hydrophilic structure. And if we say some characteristics for them, the first is that their absorption is typically more simpler. There are some exceptions, for example, vitamin B12, but in general, we can say that their absorption is simpler due to the fact that they are not dependent on the absorption of lipids. Absorption of fat-soluble vitamins will be dependent on the absorption of lipids, and if you have a problem with lipid absorption and lipid digestion, you will have a problem also with fat-soluble vitamins. Second thing is that since they are hydrophilic, they have no special transport protein inside the blood. The same as, for example, for glucose or for amino acids, they can be freely dissolved. And third characteristic is that typically we can speak about deficiencies of these vitamins, that mean hypovitaminosis, but we cannot speak about the hypervitaminosis. That means that the risk of overdose is really small, since when they are in excess, they can be excreted through the urine through your body. Of course, here we do not come with some really artificial situations where you give infusion with extreme dose of the vitamin, yes? But by normal food, you are unable to develop the overdose. And then the fat-soluble vitamin, as I mentioned, they are lipophilic, and therefore their absorption is dependent on the absorption of lipids. That means if you have typical problem with pancreas, you are missing pancreatic lipase, you will have malabsorption of lipids, you will see the same problems with fat-soluble vitamins. Second, how do we transport them in the blood? We have two options. A non-selective way is via lipoproteins, that means together with other lipids. Or a second possibility is that we have there the special carriers. Here we have, for example, vitamin D binding globulin or retinol binding globulin. So that means for vitamin D and for vitamin A, we have special transport proteins inside the blood, enabling them to survive in the water solution. And third characteristic is that typically we can store them in the body. Water-soluble vitamins we cannot almost effectively store. There is exception with vitamin B12, but for fat-soluble vitamins we have the stores in adipose tissue. That means in the tissue that's rich in the lipids. And of course also in other tissues that have the triacylglycerols and lipids inside. This can lead to the fact that for them we cannot see only hypovitaminosis, but also in some rare conditions we can see the hypervitaminosis. That means that since we can accumulate them and store them in our body, we can also reach the toxic level. And there is only some border between the physiological storage and then the situation when you can see the toxicity. But also here the toxicity is nothing so common as other diseases, yes? But per theory we can see them, and we will mention then for some of them you can achieve the hypervitaminosis.
For toxicity, does it affect adipose tissue or like?
That we will mention, it's not only focused on adipose tissue. For example, it means what do they do? That means if, for example, vitamin D does something with calcium phosphate, that hypervitaminosis will affect this. So that's only the place of the storage, we can say. The adipose tissue. And the last, that's the provitamins. As you know, we have the vitamins, and vitamins are typically converted to active compounds, typically active enzyme cofactors. then we can have compounds that are precursors of vitamins. That means that our body is able to produce from some compound a vitamin molecule. These provitamins, they have no biological activity, but once they are converted to the active vitamin, they can show this biological activity. And the best example of this is the beta-carotene. As you know, it's typically in a plant food, and it can be converted to vitamin A. As you will see when we will come to vitamin A, from one beta-carotene you can produce 2 molecules of vitamin A. And as you will see, not only one vitamin A is provitamin, the same we can see, for example, for vitamin D in our body. So, any questions to this general overview? Oh, sorry, one more thing. Function of vitamins. When we return through the last year, you could remember that at many places inside our metabolism, we mentioned this enzyme has a cofactor, and the cofactor is derivative of this vitamin. This is the most common role where are vitamins inside our metabolism. That means that they enable the function of our enzymes, and therefore, if we miss them, then some parts of our metabolism are functioning improperly, and you will see the deficiency of these enzyme catalysis inside the metabolism. If we should mention some of them, for example, coenzyme A is produced from some vitamin, FAD, NAD, or pyridoxal phosphate. All these are derivatives of vitamin of B group. We will go through them, and all of them serve as the enzyme cofactors. That means without them, we simply can run the basics of the energy metabolism. Second big group are antioxidants. Typical example of this is vitamin E from fat-soluble group and vitamin C for water-soluble group. Both of them enable our body to fight against the reactive species, typically reactive oxygen species. And as you will see, these antioxidants typically cooperate with each other. That means that vitamin C plus vitamin E, they together form a very effective antioxidant system. And third is example when vitamins serve as the signaling molecules. That means that they will produce some molecules that have active signaling function. And as you know, typical example of this is vitamin D, since when it's converted to the active calcitriol, that's the active hormone regulating calcium and phosphate metabolism. So as you see, these 3 functions are the most common for the vitamins, and if you know what's their function, then you are quite easily to define what will be the result of the deficiency. So for vitamin D, when it's increased the absorption of calcium inside our body, then it's quite logic that when you have the deficiency of vitamin D, you will have the lack of calcium for your bone stiffening. And in the adults, you have osteomalacia, and in children you have rickets. Yes, the same problem, lack of calcium, since vitamin D active form is increasing the concentration of calcium in your body. I have already mentioned it, the hypovitaminosis or complete avitaminosis means if you have lack of vitamin. This you can develop for almost all vitamins. For some of them, it's only very rare since they are almost everywhere. For some of them, it's much more common to have the vitamin deficiency. On the other hand, the excess of vitamin, that means hypervitaminosis, is not so common, and you can develop it especially for fat-soluble vitamins, vitamin A and vitamin D. For other vitamins is much more rare than for these two vitamins. So, any question to this? If no question, then water-soluble vitamins. We will go through the whole list. That means we will start with vitamin B1, then finish with vitamin B12, and then we will go to the vitamin C. So first we will review the B group. The first discovered water-soluble vitamin, therefore vitamin B1, it's called thiamine. As you see, quite long time, more than 100 years. And here you can see the active enzyme or active enzyme cofactor that we call thiamine pyrophosphate. In the metabolism, you can also see it in the name thiamine diphosphate, since you know that pyro is the same as di, or in abbreviation TPP. That means thiamine pyrophosphate, or TDP as the thiamine diphosphate. This is the structure of the vitamin itself. That means is produced by condensation of thiazole and pyridine. So you see two cycles and then the pyrophosphate. The role in the metabolism is at two basic positions. We can say in general that that's inside the metabolism where you transfer an active aldehyde residue. First is if you do oxidative decarboxylation of some alpha-keto acid. Where you know it, as the best example is pyruvate dehydrogenase complex. That means reaction where you convert pyruvate, that means alpha-keto acid, to molecule of acetyl-CoA. You do there the decarboxylation, plus you do there the oxidation of the keto group to the new carboxy group. Very similar reaction is alpha-ketoglutarate dehydrogenase. You start with alpha-ketoglutarate, you remove the carboxy group, you oxidize the keto group, and you produce the succinyl-CoA. So you see that typically you join these reactions with the coenzyme A molecule, and you produce a new CoA derivative, acetyl-CoA or succinyl-CoA in the Krebs cycle. Last example is the second step in the degradation or metabolism in branched chain amino acids. There's the dehydrogenase of alpha-keto analogues of branched chain amino acids. In the first step in branched chain amino acid degradation, you do the transamination. Then you gain the alpha-keto derivatives, alpha-keto analogues of these branched chain amino acids. And the second step, you do the oxidative decarboxylation. And you also produce the derivatives of CoA. So various stereotypic reactions, oxidative decarboxylation, and joining with the CoA molecule. Second is the transketolation reaction that you know from the pentose phosphate pathway. Also, you transfer the active aldehyde residue, and you therefore use TPP as the cofactor. Any question? Where we can find it? You know, for each vitamin you can read this long list. As you will see, for B group vitamins, you typically find them, for example, in the yeast. Yes. Good thing is to know whether there is something that is unique for that vitamin. And typically for thiamine, it was connected with one disease that developed through the fact that this vitamin is in the outer layers in the cereal grains, yes, in the coating of the cereal grains. That means that if you remove this coating, then you have the food that will be deficient in the thiamine. And typical example right now, we can mention, for example, white bread. That means that you fully remove the cover of the grain, or when you take the peeled polished rice. And of course, it depends where do you live, or what is the dominant source of saccharides in your diet. As you see here, fortified, that means that nowadays we typically, if we know that there would be a risk of thiamine deficiency, we can fortify, that means artificially supply the food with the thiamine. Yes? And that could be done nowadays. That means that the risk nowadays is not so big, since even when we remove the cover, we can the food fortify with the vitamin. Similar thing is for trace element iodine, that you can, for example, fortify the salt with iodine. And therefore, whenever you use salt, you also have iodine inside. If you eat only this, then there is a risk of development of a disease that's closely connected to vitamin. The name is beriberi, and if you open a book, it was in past very typical disease for Southeast and East Asia when they eat this type of rice, and therefore they had the lack of vitamin B1 inside the diet. The symptoms, if we return to the role of metabolism, you see that it deeply affects the metabolism of saccharides and amino acids, pyruvate, Krebs cycle, and branching amino acids. And the symptoms of this disease was the problem of the skeletal muscle, that means myopathy, the general fatigue, the anorexia, edemas, and then the cardiovascular and neurological disorders. This is the typical disease that you should know. As you will see, not all diseases are so strictly connected to vitamin. And during the exam, if you mention thiamine and beriberi, that's the typical example, were described. And if you would remove it from the diet, you will develop it. That's not true for all vitamins. Sometimes it's very difficult to develop the deficiency. Here is not so difficult. So, any question?
Was this when they invented the golden rice? Was this with to get rid of beriberi?
And what does it mean, golden rice?
They, like gene made the rice with extra vitamins in it.
That's possible.
There was a luck.
Yes, right now typically they are able to produce the different, for example, oils, different rice. So here I am not expert to tell you whether this is example of this, but as we return to the last lecture, when we mentioned that some oils are bad due to content of some fatty acids, now they produce the plant that's not producing this acid in so high amount. So that means that this could be true also. So no question, vitamin B2. It's called riboflavin, and therefore it means that its name is derived from the Latin flavus, that means the yellow. If we look at its structure, you know it from two enzyme cofactors, from the flavin mononucleotide and flavin adenine dinucleotide. And the vitamin itself is the alcohol ribitol connected to heterocyclic core. So that's this one. So this is the vitamin, heterocyclic core, the alcohol, and here you see it in the form of the enzyme cofactor. So you see this quite repeatedly, that we have this part in many, many vitamins, and then the alcohol group of vitamins bind to the phosphate, forming the active vitamin. Where we can find the FAD and FMN, typically as the cofactors of oxidoreductases. It will be similar with NAD, that we will be speaking about in a few minutes. Only, as you know, we have different oxidoreductases working with different cofactors. So example of FAD is, for example, the succinate dehydrogenase. That means the part of the Krebs cycle where you convert succinate to fumarate. Other example is, for example, beta oxidation, the acyl-CoA dehydrogenase, the first step in the beta oxidation, where you produce the first double bond, or it's inside our respiratory chain in the complex where you oxidize the NAD. That means the complex 1. And as you know, succinate dehydrogenase is complex 2. So you see, enzyme cofactor important for the very heart of the metabolism, for the production of energy, for the beta oxidation of fatty acids. Where you can find it, as you will see, it's very similar to vitamin B1. So also in yeast, in liver, kidneys, in eggs and milk. If you would return to vitamin B1, you will see it there also. The dose is almost similar, so around 1.4 milligram. And this is the vitamin where you cannot see some specific disease connected to it. As you will see, for the majority of B group vitamins, if they are deficient, you can say that you have some uncharacteristic symptoms. Typically, you have the problems in the oral cavity. That means that, for example, the corners of your mouth, you know that if you have the corner, the first treatment that you can do is take B group vitamins. And very often, this will help. The same, it will delay the wound healing, but as you will see, that will be true for other vitamins also, and you will have some uncharacteristic skin problems. So if we close it, you can say that typically the oral cavity problems, skin programs, and then the problems if the tissues must divide rapidly, yes, since it's in the very heart of the energy metabolism. So any question? Vitamin B3, that's what I previewed to you. Vitamin B3, that's niacin, and this means two compounds, nicotinic acid or nicotinamide. So here, these two compounds in amide form will be inside two enzyme cofactors that will also work as the cofactors of oxidoreductases, only different oxidoreductases from vitamin B2. The active enzyme cofactors is NAD or NADP. That means nicotinamide, adenine, dinucleotide phosphate, or without the phosphate. So here you see the structure. So here you see the nicotinamide, and as you see the same here, the phosphate and adenine. The only difference between these two enzyme cofactors is here the phosphate. So very similar. Where we can find them in the metabolism, you know that these two enzyme cofactors have typically different group of enzymes they react with. So NAD is found typically in the oxidation pathways. We can see them in Krebs cycle. We can see it inside our glycolysis. We can see it in pyruvate dehydrogenase reaction when it takes the electrons and hydrogen from the pyruvate. We can see it in beta oxidation. And then it gives the electrons inside the complex 1 of the respiratory chain. So that's the role of NAD. NADP is typical cofactor for reductive synthesis. That means, for example, for the synthesis of fatty acids, you use per one spin 2 molecules of NADP, H. Then in the cholesterol synthesis, also reductive synthesis, you utilize their NADP. and the place where you produce the reduced part, the reduced form, that's the pentose phosphate pathway, or the malic enzyme inside the citrate shuttle. That means that also here you see the role very deeply inside the metabolism, and you can close it that it's the role inside energy generation, inside the final utilization of your nutrients when you want to gain energy from them. Where we see them, or where we can find it, you see very similar list. So typically it's in yeast or inside animal, that means in the liver. And there is one special thing for this vitamin, and that's the thing that in some reduced amount we can produce them inside our body. But as you see, the conversion rate is not very friendly to you. You can produce it from tryptophan, and the conversion rate is 60 milligrams of tryptophan giving you 1 milligram of B3. That means that you have some ability to produce it, but before you will use this, you will use the tryptophan for all other purposes. Yes, as you see, we are snowing right now. When I saw it at the midnight last day, that I thought whether there won't be a calamity and traffic jam everywhere in Prague, but fortunately the snow went down before the morning. Therefore, it's good to go with the metro and not with the bus when you know that it's snowing and we have 10 centimeters. The first 2 days are very, very bad here in Prague. So this is the example of the vitamin when we have some limited ability to produce it. So we are not so fully dependent only in the diet, and the deficiency typically occurs when you are missing both or you have limited amount of tryptophan in the diet. For vitamin B3, you have also one disease that's called pellagra, and this is the typical disease of 3D. Thus is called 3D disease, and it means that you have dermatitis, 1D, then diarrhea, 2D, and the dementia, 3D. But nowadays, this disease also not anything common, yes, in developed worlds. For as you see, this you can see inside our diet. Any questions to this B3? B4 is missing. Why? We will explain at the very end. B5. B5 is called Pantothenic Acid. It's taken from two groups, from pantoic acid and beta-alanine. This is the acid, this is the beta-alanine, and this is the pantoic acid. And as you see, this vitamin is the part of the big molecule of coenzyme A. So this is the big coenzyme A. And here you see phosphate, hydroxy, and this is the way how the vitamin is bound to the part that we can produce in our body. And here you have the part where you bind through the sulfur the working acyl group. So vitamin B5 is is metabolized to give you a product called coenzyme A, and therefore is absolutely necessary for the pathways of lipid metabolism, since you know that all fatty acid derivatives, when they enter the cell, they are bound to coenzyme A, and as you know, afterwards the acetyl-CoA will enter the Krebs cycle. So you can mention this pathway for the role of vitamin B5. The name pantothenic acid is taken from the Greek pantothen, that means everywhere. And that means that this vitamin you typically can find almost everywhere in the food. It's in plant, it's in animal food. And therefore, if we come to the deficiency is not very common, yes? It's only very, very rarely, and if you see what's the symptoms of the deficiency, also some skin problems, yes? So in general, the B group vitamin problems. The daily intake is quite high when compared, for example, to B1 or B2, but since it's really almost everywhere, this is not a vitamin where you do deficiency you can see.
Well, what kind of things does not have it? And does those like life forms don't?
For example, water, I think, does not have it. Yes, but this is the typical so crucial vitamin for so many animal species that you can find it, or not only animal, but also plants, that really you can find it in many, many things. Typically the whole grain things contain them, then the yeasts, but really this you can find in relevant quantities where you have it. So the disease here has no name for, it's not some specific disease that you will develop. Vitamin B6. Vitamin B6 is called pyridoxine, but that's only one of the forms. We have the form pyridoxine, that means alcohol, that we have pyridoxal, that's aldehyde, and then pyridoxamine. If we look, here you have their structure. So the structure is quite simple. And as you see, the difference is that here we have alcohol, here we have the aldehyde group, and this is the pyridoxamine. In the active form, you know this vitamin as pyridoxal phosphate. So this is the pyridoxal phosphate, this is the pyridoxal, and through the hydroxy group, you bound it to the phosphate. And as you know, pyridoxal phosphate is absolutely crucial for the amino acid metabolism, since it catalyzes the transamination reaction, and also it catalyzes the decarboxylation. And as you know, both these reactions are absolutely crucial for normal amino acid metabolism. And for example, without these reactions, we simply cannot run the simple neurotransmitter metabolism. As you know, many of neurotransmitters are amino acids or they are derivatives. Where you can find it, here very similar to the previous, so it's found in many types of food, so nothing quite special where you can find it, and therefore also no special type of deficiency. So here the isolated vitamin B deficiency is also rare, the same as for B5 and some of the previous. So here we also close it with some uncharacteristic symptoms. That means problems with oral cavity, problems with skin, and then, for example, the problem with the CNS function. Question? Vitamin B7. Vitamin B7 you know as biotin, or you can read about vitamin H. This means still the same thing, and this vitamin is a derivative of imidazole. So if we look at it, this is the structure of the molecule. As you know, biotin typically in our body as an active molecule consists of the carboxybiotin form. That means that enables the transfer of carboxy group through our body, and it's in the direction of carboxylation. That means adding of a new carboxy group to the molecule of substrate. Two examples that you know from the energy metabolism. First, regarding the lipid metabolism, is the synthesis of malonyl coenzyme A. That means the first reaction of synthesis of fatty acids, where you convert acetyl-CoA to malonyl-CoA. Second is the anaplerotic reaction of the Krebs cycle, and the first reaction of gluconeogenesis from pyruvate. That means the conversion of pyruvate to oxaloacetate. Pyruvate has one carboxy group, one keto group, and 3 carbon atoms. And if you add to the methyl part a carboxy group, you will generate a dicarboxylic acid, oxaloacetate. Both these are 2 simple carboxylations, and they are enabled by the enzyme cofactor carboxybiotin. On this scheme, you have the precise theory of the reaction. You do not have to know it in detail, only you should know that first you take the carboxy, you bind it to the biotin, forming carboxybiotin, and then you add it to the working substrate. So in this example, it's the coenzyme A that will be, or acetyl coenzyme A that will be carboxylated. For this vitamin, it's important to know that we can find it in our food, that's true, but we produce it in high quantities inside our intestine by our bacteria. And therefore, the biotin that's inside the food is not so crucial, and the nutritional deficiency is not the biggest problem you can have. On the other hand, what can be the problem is when you do the deficiency indirectly. That means if you first limit the production in your intestine, for example, by the antibiotics administrations, since they will destroy the microbiome, they will limit its function, and therefore this can lead to insufficient production of vitamin B7. And then you are much more dependent on the food. Not all vitamins that we produce in intestine we can absorb. Yes, some vitamins that are produced in large intestine cannot be no more absorbed. But this vitamin we do not only produce, but we also can absorb it. And therefore, per definition, is not so big vitamin for us, since our body is able to produce it only with the help of the bacteria that we have.
Is it produced any vitamins in small intestine?
Yes, you know that you have in stomach no bacteria, and then the amount is growing. So both the small intestine and the large intestine, but in the large intestine you have the highest. You have the highest portion of bacteria. But of course you can produce it, small intestine is quite long. So not in the duodenum, but then in the ileum you can produce the vitamins. And then subsequently in the large intestine, only some of them you can absorb. Vitamin B9. Vitamin B9 is a typical example of vitamin where you know quite in detail the function already. And we expect that for this vitamin you will know the whole cycle. That means where it's in the food, where in the metabolism, and since it has the specific deficiency, you must know it also. The name folic acid tells you where you can find it. Yes, that typically you can find it is something what's green, yes, in the vegetable. Altogether, when we take folic acid and its derivatives that are folates, we call it altogether folacin. But if you speak only about folic acid, it's enough. You only should know that we have also the group of compounds that together are vitamin B9. If we look at the structure is shown at this picture. So as you know, it's one of the bigger vitamins. So here you have the aromatic ring called pteridine. Then here you have the para-aminobenzoic acid. This altogether is called pteroic acid. And the last part are the glutamates. You will see that it's important to know the structure since we will use it in the pharmacology, yes? That we will use some drugs that will mimic the structure of one of these to destroy the vitamin synthesis in bacteria. Inside the food, here typically you do not have only one glutamate, but you have it in the form of polyglutamates. Before the absorption, you typically degraded the polyglutamates to the monoglutamate folate. And then these can be much more easily absorbed. So there is some limitation in absorption. First, you must degrade the polyglutamate to monoglutamate, and they can be much more easily absorbed. You know that this vitamin typically exists in our body in many, many forms. First is that the enterocytes convert the folate to dihydrofolate. If you look, I choose this picture since here you have R and X, and you can see what's modifying the molecule. So here we have unreduced folate, dihydrofolate, and tetrahydrofolate. And here you have the carbon numbers where the change is done. So the change for dihydro and tetrahydrofolate is in this part of the ring. Dihydrofolate is subsequently reduced by dihydrofolate reductase, and this enzyme will give you the molecule of tetrahydrofolate. As you start with the first, that's folate, then 2 hydrogens, dihydrofolate, other reduction is tetrahydrofolate. And as you know, the tetrahydrofolate can bind different C1 carbon residues. And it will return to the picture, that's the R1. So to this part of the molecule, you can bound C1 carbon residues. And you see that we have quite long list of them. The most common that you should know that exist is methyl, methylene, methanyl, and formyl. And these C1 residues have different degree of oxidation, and therefore they are incorporated inside the metabolism at different places. 2 places you should know as the basic. Both of them are related to the DNA metabolism. First is related to pyrimidines. And the folate molecule in the derivative, the methylene tetrahydrofolate, you will use in the reaction where you produce thymine. You know that thymine is important for the DNA synthesis, that's the difference between RNA and DNA. And if you want to produce DNA, and one of the base, you must have the methylene tetrahydrofolate for the enzyme called thymidylate synthase. Second place, only different oxidative state, that's the formyl tetrahydrofolate, you will need for the synthesis of second group of nitrogen bases. And that's for the purines. So we can close this, that without the active tetrahydrofolate derivative, we cannot produce our DNA, since you are not able to produce both parts of the DNA, purines and pyrimidines. The whole cycle you have here. So here you have methylene tetrahydrofolate, thymidylate synthase, adding of methyl, and you are producing thymine, and then the conversion to formyl tetrahydrofolate, giving you the cofactor for the purine nucleotides. What do you know about this part of the cycle? That means the interaction between vitamin B9, that's folate, and vitamin B12, that means cobalamin. What do you remember from the first year? That's through methylation. But what's the relation between vitamin B12 and vitamin B9? So, methylene tetrahydrofolate can be converted to methyl tetrahydrofolate. And this must be regenerated by vitamin B12. It will take the methyl from it, producing methyl cobalamin, and you will regenerate the tetrahydrofolate. In this form, you can say that it's something as the waste, yes? It's the blind line, you cannot go further unless you have vitamin B12. And the vitamin B12 itself will use this methyl to convert homocysteine to methionine. And this is the part of the other C1 carbon cofactors, that's the S-adenosyl methionine, as you know. So that means that for the proper metabolism of C1 carbons, you must have two vitamins, B9 plus B12. B9 you typically use for the synthesis of DNA. B12 you use for the regeneration of tetrahydrofolate. And if you will miss both or only one of them, result will be in one part of the metabolism very similar. That means the inability to produce DNA. Do you understand this? Where you can find vitamin B9, as we already said, in everything what's green, simple the definition. So it's inside a vegetable and typically in the plant food. Also, it's as the whole B group vitamins inside the yeast, inside the liver, in eggs and milk. The recommended daily intake is quite small if you are adult, it's around 0.2. But do you know when we increase this dose, in what special group of population we do increase it? In pregnancy, and that's due to the fact that the folates typically prevents the development of the congenital defects. Typically you can read about spina bifida, and then it also prevents the abortion and premature birth. So if you have the pregnant women, you typically supplement it with vitamin, with a folate, and if you have somebody that has abortion in the history or some problem in general in pregnancy, you typically also supplement the lady with the vitamin B9. You know that in the exam you have the question about pregnancy, so vitamin B9 is good for pregnancy. On the other hand, vitamin A could be harmful during the pregnancy. Yes? So these are those two vitamins related to pregnancy. And if we return to the disease that develops when you are missing vitamin B9, it's the macrocytic megaloblastic anemia. That means that you have anemia. That means low concentration of hemoglobin. And it's macrocytic since you have big cells. That means that you are limited at the number of DNA produced, if we make a simplification, but you have no problem with the production of hemoglobin. And therefore you will produce lower amount of big cells. And therefore it's macrocytic anemia. The deficiency is typically not only due to lack in the food, but we, in some diseases, actively put a disruption into the folate metabolism. The drug that you could know is called Methotrexate, and Methotrexate is inhibitor of dihydrofolate reductase. Therefore, it's blocking the conversion of dihydrofolate to tetrahydrofolate, and therefore is blocking the conversion of folate to the intermediate that can carry the C1 carbon. Therefore, we also call it as the antifolate drugs. So the inhibitors of dihydrofolate reductase are antifolates. What will be the result? result will be the inhibition of cell division, and typically it affects the rapidly dividing tissues, and therefore it can be used in the treatment of, for example, hematological malignancies, where the cells really rapidly divide, and methotrexate is used in the combination with other drugs in the treatment of some hematological problems. Second is that you can use it for immunosuppression, since it lowers the cell division. Therefore, it also shows to immunosuppressant effect. And you will see that it can be used, for example, in dermatology, in the transplantation medicine, where you want to suppress the immune response of your body. And if we return to the structure, there is one other usage of the folate metabolism in the treatment of human diseases. You know that we have antibiotics, and the second group are sulfonamides. Sulfonamides are older group, but nowadays, since the antibiotic resistance is growing, the sulfonamides return to the prescription. The way how the sulfonamides work in folate metabolism is quite simple. Bacteria can produce folate. Our body cannot produce folate. Therefore, if you put something that resembles a structure for the folate synthesis, you will modify the metabolism of bacteria, but not our human metabolism. And the sulfonamides, they resemble the para-aminobenzoic acid, and the bacteria will try to incorporate the acid into the molecule of folic acid, forming an inactive intermediate. And therefore, you can use this as the selective blockers only for bacteria and not for the human tissue. Example of these drugs is, for example, Biceptol used for the cystitis. Yes, that's quite common drug. You know that it's quite routinely prescribed, and the mechanism, how it works, you should know. Vitamin B12 structure is the Corrin ring that has several functional groups on it. If you look at the structure, you do not have to know it, only if you look at it, that here you see that it's different from the porphyrin ring. Yes, the porphyrin ring is tetrapyrrole, and as you see, this is not a tetrapyrrole, but altogether, the structure is quite similar, and as you see, this is one of the most difficult vitamins that you will meet. It exists in the form of several vitamers. It could have the hydroxy group, the methyl group that we already know from the folate. It can have a cyano group or deoxyadenosyl group. The active molecules, that's the methyl and the deoxyadenosyl cobalamin. If we look at the methyl that we have already mentioned, it enables the regeneration of tetrahydrofolate from methyl tetrahydrofolate, and the reaction the methyl cobalamin produces is the conversion of homocysteine to methionine. The enzyme is called methionine synthase, and this enables the regeneration of S-adenosyl methionine, the donor of C1 carbon, for example, for the synthesis of adrenaline or for the synthesis of choline. That means the constituent of the phospholipids. Second position inside the metabolism is the conversion of methylmalonyl coenzyme A to succinyl-CoA. And as you know, this is important for the metabolism of some fatty acids, since, as you know, some fatty acids can give you the intermediate of the Krebs cycle, that are those with the odd number of carbon atoms. For cobalamin, you should know that its absorption is quite complicated, and it's not so simple as for other vitamin of B group. If we start, you know that vitamin B12, when inside the stomach, it can join together with intrinsic factor produced by the parietal cells of the mucosa of stomach. And when you have this complex, you can, inside the ileum, do the receptor-mediated endocytosis. That's the selective process for the absorption of vitamin B12. Therefore, you also see two possible problems that can lead to the disruption of vitamin B12 metabolism. The receptor is called cubilin, and after it, you transport the cobalamin in the blood. In the blood, you typically transport it with the partner that's called transcobalamin type 2, and the transcobalamin type 2 can be subsequently cached in the tissue and stored inside our body. For vitamin B12, it's true that this vitamin can be stored in our body. The B group vitamins we do not store typically in high quantities, but vitamin B12 we store in quite high quantities. If you see, our body reserve is around 2 to 5 milligrams, typically inside the liver. And the recommended daily intake is only 2 to 3 micrograms. So the difference is 10 to 3. And this recommended daily intake is the lowest from all vitamins. And since we have quite big body reserves, the deficiency can develop, but it will durate some time. And therefore also, you cannot finish the treatment of the deficiency only when you return to normal physiological values, but also you must continue with it, since the deficiency really develops when the body stores are depleted. So you can say that your body reserve can serve you well many years, or not many, 2, 3 years, if you have really total lack of the vitamin. For vitamin B12 is also crucial where you can find it. Vitamin B12 is produced by the microorganisms only, and animals store this vitamin. Problem is that in plants, you have the cobalamin only if you have any contamination. That means that the plant diet is very poor in vitamin B12. For example, you can find it in the fermented cabbage, but it's due to the fact that there is the contamination of bacteria. But in normal plant diet, the amount is really, really low. And therefore, this is the vitamin where you have the risk of deficiency in the vegan diet. If you are not taking into account this thing, that you must have there the bacterial contamination, you can develop the deficiency. It's similar as that you, for example, can have the iron deficiency in the vegan diet. But if you think about it, then there is not this kind of problem. This vitamin, you can read that it's produced in our colon. That's true, since we have there the bacteria. But the problem is that it's too late. Since the absorption must be done in terminal ileum, it's quite complex, and therefore in the colon you can produce it, but you will also lose it from your body with this tool. So you cannot absorb it. What are the most common reasons for the deficiency? Most common reasons are two. That means that you have the problem in the stomach, where you produce the intrinsic factor. So for example, if you have the surgery where you remove big part of stomach, you can have problem. Or if you have the autoimmune gastritis that targets the cells producing vitamin B12 intrinsic factor, you will also have deficiency. And these conditions are not so rare. Second is if you have ileal disorders. So the patients that have inflammation or resection at this part of the GI tract will be more vulnerable to the vitamin B12 deficiency. The result of this deficiency will be to some extent similar to folate. But you must know also that it's not absolutely the same, and you as a doctors must be able to distinguish these two types of deficiencies. The first, where it's the same, is the macrocytic megaloblastic anemia. The reason here is that since you are not able to regenerate folate, therefore you are missing active cofactor for the purine and pyrimidine synthesis. Therefore, you have not enough DNA for the rapidly dividing cells, and as example, you develop anemia. You will meet the term pernicious anemia. This pernicious anemia is related to vitamin B12 deficiency that's caused by the autoimmune process. Yes, and you will heard about the pernicious anemia really frequently, since this is also one type of the typical diseases where it's quite clear the pathophysiology behind. The problem is if you see patient with this laboratory result, and as the treatment you will give them folate, since you think that the problem is the folate. In that time, you can mimic the situation that the disease was treated, that the deficiency was treated, but when it's the vitamin B12 deficiency, there will be still the second silent process that will lead to the result of the deficiency that's different from the folate deficiency. And that's the demyelinization that's also typical for vitamin B12 deficiency. The pathophysiology is not here on 100% sure, but what we know is that B12 you need for production of methionine. Methionine in form of S-adenosyl methionine will methylate ethanolamine to give you choline. And the choline you need for the production of the myelin sheets. If you are missing B12, the result is demyelinization. That means the problem with the axons, and typically the most affected are the posterior and lateral spinal tracts. And if you treat with folate this disease, this will still proceed, and it can lead to the harmful result for the patient. Therefore, when you see patient with macrocytic megaloblastic anemia, you must distinguish whether it's folate deficiency, then give folate, or the second reason, give B12 when it's B12 deficiency. How do you think that we will administer the B12 if you have the patient with B12 deficiency?
Intravenous?
That's true, or typically we give it in intramuscular, but you can also intravenous if you have the parenteral nutrition, but typically we give it intramuscularly, and why not through GI tract? Yes, if the problem is here or here, if you put it, then it cannot be absorbed. If the problem with vitamin B12 deficiency is lacking the diet, then you can give it to the patient in this way. But typically you give it, if I remember it correctly, it's the red color liquid that you give intramuscularly, yes. And if you see somewhere something that's red in the ampule, you will know that it's quite high probability it's vitamin B12. Any question?
What was the name of the receptor?
Cubilin. Vitamin C. Vitamin C is the last water-soluble group. As you know, this vitamin is quite simple. It's called ascorbic acid. And in the redox system, ascorbate and dehydroascorbate, it works as very important one, antioxidant, and second, cofactor of hydroxylases. We cannot produce it, this vitamin, but its synthesis is quite simple and majority of vitamins can do it. It's produced from glucuronic acid, as you know, that simply exists in our body, but we as primates and then some few other species miss the enzymes to produce ascorbic acid. But in all other living forms is not a big problem to synthesize vitamin C. Here you have three basic roles of vitamin C. First is that it helps with the iron absorption. It reduces iron +3 to iron +2, and therefore it's helping to absorb, since you know that the divalent methyl transporter takes the iron +2, especially from the food and from the lumen of GI tract. Second is that vitamin C is cofactor of hydroxylases. Two examples of this. First is the synthesis of collagen. That means proline and lysine hydroxylase. And second is the synthesis of noradrenaline by the dopamine beta hydroxylase. So if you are missing vitamin C, you will miss these two important metabolic processes. And third is very important antioxidant, and especially it works with in the couple with vitamin E, since it will regenerate this antioxidant, and vitamin E typically works against the lipoperoxidation inside our membranes. Where you can find it, you know the long story where inside the food you can find it, so typically in the fruit, in vegetable. So we have it in the cabbage, cauliflower, blackcurrant, tomatoes. Citrus fruit, they have some amount, but not so big amount, yes. You know that if we say vitamin C, all people see lemon, orange, grapefruit, and these, but that's not at the top. But still the amount there is quite big. Story about potatoes is quite simple. We do not eat, we eat them a lot, and the average amount inside is not so big. But if you take into account the very big consumption, especially in this part of the world, they are really one of the main source. And before administrating potatoes into the diet, there were really much bigger parts of the world suffering from the lack of vitamin C. So taking the potatoes from America really decreased the level of the deficiency, for example, in this part of the world. What's the side effect of this vitamin is that it's quite sensible to changes, to be destroyed, high temperatures, and then contact with metal utensils typically decrease the amount of vitamin C. But if you eat, for example, 1 kilogram of tomatoes, still you will have enough, yes, even when you use a knife for it. Recommended daily intake is very high, it's around 60 to 80 milligrams. So as you see, very high intake. B12 was the lowest, and here you see how big amount you also can use.
When you say high temperature, how high do you mean?
The higher the worse. You know, since it's working as the redox system, then everything that causes high temperature will also influence this redox system. So if you boil it at 200 degrees, the level really decreases. But it depends on the temperature and the length of the cooking. But back if you return here, have you seen here anybody with scurvy? Right now, also nobody. Yes. So it's not so common, and it was in the past. Yes, the problem here. And nowadays, since we have here, even during the winter, fresh fruit and all these things, then the problem is not very big. Yes, in the potatoes, the problem is if you have long-term storage. So if In the past, people took the potatoes, put them, and let them half a year. Then at the end, the amount of vitamin C was there lower. Yes, but nowadays this problem is not so big. The disease that you should know here is scurvy, especially due to the historic perspective, since here at this region in Europe it's not very common. But you should know how it looks like. The typical problem here is the problem of collagen synthesis. That means that you have reduced resistance of skin, reduced resistance of capillaries, therefore you have bleedings, then reduced strength of the fixation apparatus of the teeth, therefore the people could lose their teeth. But all these things together means the impaired production of collagen inside your body. And the collagen you need, of course, for all these things. The hypervitaminosis typically does not exist, since you can excrete vitamin C in the urine. Problem is that if you have a lot of vitamin C, that it will interfere with laboratory tests. So it can modify the results of the laboratory test. And if you see some strange results, then you must take into account that it could be also vitamin C. And it's not uncommon that the people really take high doses, since they think that it will protect them against the infections, or that it will treat almost everything. Yes? In that situation, it really can modify the lab results. So, question to vitamin C. Fat-soluble vitamins. Vitamin A. Vitamin A is the group of compounds. You will heard about retinol. That's the most common. Then retinol and retinoic acid. If we look at the molecule, this is retinol, so hydroxy, retinol aldehyde, and retinoic acid, that means the carboxy group. And here you see the beta-carotene, and as you see, from one molecule of beta-carotene, you produce 2 molecules of vitamin A. You see this is one part, and this is the second part of the molecule. What's the function of vitamin A inside our body? First, what we can say is that since it's the fat-soluble vitamin, it has quite good ability to affect the gene expression, similar to steroid hormones, through the intracellular receptors. If you return to the previous year, you know that there are some molecules that work through intracellular receptors, and that was typically steroid hormones, retinoids, and then vitamin D. They share the same characteristic, quite high lipophilicity. We should mention 3 functions of vitamin A. First function is that it's important for the tissue differentiation and tissue growth. And especially this is important for our epithelial tissues. And from this comes the fact that it's quite often used in the dermatology if you want to treat some severe skin disorders, as is, for example, acne and psoriasis. It's not the only treatment, you have other options, but retinoids can be sometimes used in the treatment. Yes, they help with the transport of oligosaccharides through cell membranes, and therefore enabling the normal tissue growth and differentiation in epithelial tissues. Second, as you know, retinol is inside the visual pigment rhodopsin. That means that without vitamin A, we have the problem with the vision. The precise mechanism, metabolic pathways, you will do in the summer semester. Today you should only take that retinol and opsin makes together rhodopsin visual pigment. And third is that vitamin A and beta-carotene, they work as the antioxidants. So similar to vitamin E and vitamin C. Where you can find it? You can find it first in the form of vitamin A, and then you will find it in animal products. Typically, you can read about fish oil, in the egg, in the liver, and inside the butter. Or you can find it as the provitamin, beta-carotene, and that you will see in the plant products, typically in vegetable. And I think that all of you know the orange carrot is rich in the beta-carotene. What will happen if you have lack of vitamin A is the problem, especially in your epithelial cells at the mucuses. First problem is that you will have the reduced secretion of your mucus glands. This will cause the dryness of, for example, your oral cavity. But what's more severe is the problem of your eye. You can have the problem that's called xerophthalmia. That means lack of tears. And this can even cause the blindness. And nowadays it's not so common, but in the past it could be really one of the severe results of vitamin A deficiency. Other thing connected with the eye is called hemeralopy. That's the night blindness. That's the first time when you can recognize the deficiency, and that's the problem that, especially during the night vision, you must have a lot of this rhodopsin. That means a lot of vitamin A. And the people that had the deficiency first realized that they can have the problem in the vision during the conversion of day to night, when their receptors in eye must adapt to this new occasion and to have a higher sensitivity. And the people that have hemeralopy have the problem with the adaptation of their eye to the night. And third, that's the problem with the skin. So altogether you have increased keratinization of your skin. And you know that, for example, psoriasis is a very big extreme situation when you have very high keratinization of the skin. And therefore retinol can be used for the treatment of them. You can have the hypervitaminosis of this vitamin. Described, I think, in quite a lot of books is the story when you eat a liver of the polar bear. So then, since there is very high quantity of vitamin A, you can develop the hypervitaminosis. The only question is how frequently do we eat the liver of a bear? Yes, I don't think that is very common, but if you want to develop hypervitaminosis, this is an excellent way how to do it.
I heard you can die from this.
Yes, you can die.
Yeah.
But fortunately, we do not have bears so much here. And we typically do not eat them. But you can die from it, yes. If you go to really toxic values, it causes the liver damage especially. What's more common also here is this, the teratogenic effect. Since it modulates the cell signaling, vitamin A can modify the development at the beginning of your life, and therefore it must be excluded in, or the therapy with retinoids in pregnant women. And if the woman that can have a children want to gain the retinoid therapy, there must be effective way of contraception in these women. For really, the teratogenic effect here is prescribed, and therefore you must exclude the possibility that there will be fetus plus the retinoid therapy. If you eat a lot of carrots during pregnancy, there is no problem, since the body can regulate the amount of beta-carotene converted to vitamin A. But if you put retinoids to treat psoriasis, asthma, then the levels are really high, and it can lead to abortion or to congenital disorders. So this vitamin, not with pregnancy. So since we ran out of time, the rest I think you will have to know, do at home, sorry for it. Vitamin D, I put it at the last for, you know about it quite a lot. Vitamin K, you know it's important especially for the blood bleeding. So that's also one vitamin. And vitamin E, you have here described how it works as the antioxidant of membranes. Yes? So if you have any question to these 3 vitamins, that you can email me and we will answer it. Yes?